Hello, in this video I will be talking about sentinel lymph node biopsy. Before I go on, I want to invite you to subscribe to our channel because we're always putting out new content, often because you have suggested something in the comments. So if you have an idea and it's not already on our channel, just pop it in the comments and you might be surprised to see it show up pretty soon. I'd also love to invite you to go to yerbba.com to get your personalized Yerbba report. So what is a sentinel lymph node and what is a sentinel lymph node biopsy? So a sentinel lymph node is the first lymph node that drains a particular tissue. So anywhere in the body is drained by or sort of cleared or cleaned up by lymph nodes. In the case of breast cancer, sentinel lymph nodes reside in the armpit. So imagine if you had a tumor in the left breast, the lymph fluid will drain into the armpit lymph nodes or the axillary lymph nodes, and 1 to 4 of those nodes are kind of the sentry nodes or the sentinel. A sentinel is a guard. And remember, lymph nodes are doing a job by catching up infection and tumor cells. If we can identify the 1 or 2 or 3 or 4 lymph nodes that are the sentry nodes, it can tell us a lot and it can help guide our treatment, which I'll get to in just a moment. So again, a sentinel lymph node, and I'm saying node and then I say 1 to 4 nodes because the average that we see is between 1 and 4. The surgeon, to identify the sentinel lymph node, will inject a blue dye and or a radio tracer. And this is done under the nipple or near the tumor, and this can even be done in somebody who's had a mastectomy after the mastectomy, because it seems that the same nodes will drain the mastectomy scar as drain the breast itself. That's relevant only if under particular situations, but I did want to mention that. So the dye and or the radio tracer are injected, and then in the operating room, the axilla, an incision is made under the arm, and we use the radio tracer to find the strongest lymph node, the strongest signal, that node that's taken up the most of that radio tracer or the most of the blue dye. And some surgeons use just one and some another, and some will use both. The highest yield rate or identification rate is with both, but most surgeons now are so facile with the procedure and so experienced that both are not necessarily needed. We are successful in identifying the sentinel lymph node more than 95% of the time. When the sentinel node is identified, it's removed from the armpit and sent to the lab, where it's processed and later reported out. We can do a frozen section where we just look at the frozen lymph node, but you can have false positives and false negatives. So we really don't like to do frozen lymph node assessments, but rather send the full specimen for full processing. The surgeon doesn't know how many lymph nodes they're removing. It's really important to know that we can't look in somebody's armpit and say, you have 35 lymph nodes or you have 8 lymph nodes. It's really based on what they see in terms of the dye and the radio tracer, the sort of signal that we get from those lymph nodes. So I just want to take a quick aside. I've referred to sentinel lymph node biopsy and sentinel lymph node assessment. The reason I use the word assessment is because a biopsy is when we take just a part of something. So if you have a biopsy of a tumor, we don't take the whole tumor, we just biopsy and take a piece of it. When a sentinel lymph node is removed, we're removing the whole node. And so for me, assessment feels more accurate, but you will see it referred to as a sentinel lymph node biopsy or a sentinel lymph node assessment. They are exactly the same thing. So why do we do this? We do this procedure to help us stage the cancer. The most important thing we want to know is, do you have cancer in the lymph nodes? If the lymph nodes are clinically negative, they're not enlarged, we're not seeing them, we're not feeling hard lymph nodes, or we're not seeing them on imaging where they look really suspicious. If the sentinel lymph nodes are negative, it is very likely that all the other lymph nodes in the armpit are also negative. And this will spare somebody from having all those lymph nodes removed. So it's a less morbid procedure, fewer side effects, and it's actually a little more precise because more sections are taken of what's considered a high yield lymph node, a lymph node that we know is very likely to be the ones where those cancer cells were sort of caught up. If the lymph nodes are positive in the sentinel lymph node, there are a couple different branch points. One is, let's say they're all positive and they're really positive. It is very likely that you will be advised to have a full axillary lymph node dissection. And we have a videotape about that, so I'm not going to go into that. But imagine if we remove 3 lymph nodes and they all have cancer in them and it's not subtle, then we are going to want to make sure that we're not leaving any lymph nodes behind in the armpit to come back down the road. Now here's something really interesting to know about. If you have 1 to 2 positive lymph nodes only, and ideally you have a negative sentinel lymph node as well, it's been shown in a clinical trial that you actually do not necessarily have to have a full lymph node dissection if you will be getting radiation therapy. So if you're going to have radiation therapy, the armpit part of the breast and the armpit are likely to be included in the radiation field. And if you had a low tumor burden in your lymph nodes, again, 1 or 2 lymph nodes, then you can likely omit having a full axillary node dissection. Now there's another in-between state where people have a microscopic focus of cancer in the lymph nodes, 1 or 2 very small areas, and treatment in that case depends on a lot of other things, the likelihood that the tumor is going to come back based on the tumor biology, for example. Does everybody have to have a sentinel lymph node biopsy? It turns out that not everybody does. If you are 70 and over, if your tumor is hormone receptor positive, if your tumor is HER2 negative, if the lymph nodes are clinically negative, and if you are going to take endocrine therapy, meaning tamoxifen or an aromatase inhibitor, we don't need to do a sentinel lymph node. In fact, we are so confident that you don't need to have a sentinel lymph node assessment done because of a randomized trial. And this is now in the Society of Surgical Oncology's sort of canon. It's in the Choosing Wisely campaign that we can de-escalate and omit this procedure in people who meet all of those criteria. You know, it's very likely that we'll expand the criteria so more and more people can have a sentinel lymph node omitted. They don't have to have it, but at this point, these are the criteria for omitting a sentinel lymph node. What's the impact in terms of long-term effects? Well, the thing we worry about the most, as you probably know, is swelling of the arm and chest wall and breast. That's called lymphedema. We have a very thorough video about lymphedema that you can watch that has a lot of tips, many of them from the viewers in the Yerbba community. But in brief, sentinel lymph node assessment, biopsy, or dissection does not eliminate, but does reduce the risk of lymphedema. So it's a very helpful thing to do less surgery, and it's one reason that we're really pleased with the data supporting use of sentinel lymph node assessment. If you have a sentinel lymph node procedure, you're going to have an incision very small under your arm. Your arm may feel heavy, boggy, you may have numbness, and you may end up with lymphedema. So it's really important to be aware of those side effects and to get early attention if you develop swelling in your hands, in your arm, or in your chest wall. And if you want to learn more about sentinel lymph node, should it be done in your case or can it be omitted, I want to invite you to go to Yerbba.com. Yerbba.com takes your medical records once you give us access or upload your medical records from anywhere in the world and generates a report of everything we know about your tumor and everything that's been done in your case, all the test results and all the procedures that you've had. It then cross-references everything we know about your specific case with the latest medical evidence and generates a list of options, things you may hear about when you go see your cancer team, and tells you the pros and cons of these. It also suggests questions that you can ask your medical team, helps you go into that appointment prepared to hear what you're going to hear, which makes it so much easier to absorb the jargon and all the stuff that the medical team will throw at you. We are jargon-free, 100% guaranteed. Anyway, thanks for watching, and we'll see you next time.